This is International Gaucher Day, and International Gaucher Alliance is having this webinar on home treatment to support national organizations to support patients and families worldwide in their efforts to provide home treatment in their own countries. My name is Vesna, and I'm the chair of IGA for those who don't know me. And here we have wonderful people joining us today as panelists, as speakers, and I hope we will be able to answer most of your questions. Thank you everyone for sharing stuff on social media today. Our administrator communication manager Joe was very, very great in this, sharing on Facebook and Instagram, and people were resharing her posts. We had many lovely pictures from our member organizations, and we are thankful for that, because without showing what freedom means, what home treatment means, we can't actually talk about it. So to start this off, I will show you first a video. And this video is a very short interview, 10 minutes, and it's Callum and Maddie talking to Niamh. I hope I've said the names right.
Hi, Maddie. Hi, Callum.
Oh, yeah.
Thanks for joining today to have a little chat about your journey with independently infusing your enzyme replacement therapy. How are you doing?
Yeah,
Good,
we're
thank you.
doing all right. Yeah, making the most of last bit of summery weather, I think, before...
Good, good. Well, I'm going to ask you a couple of questions, Callum, in a bit, but I thought it might be good to start with Maddie, because Maddie's had many, many years of having her infusions with different home care companies, and it would be great to hear just a short bit about your journey of the different levels of dependency you've been through over the years.
Yes, thank you, Niamh. So since I was diagnosed in 1996, I've gone through all different, stages of being dependent, independent, and then now Callum giving me my infusion. But originally, my mum gave me my infusion. So when I was discharged from hospital at Great Ormond Street, the team there had to make sure that my mum could cannulate me before sending me home. I was fitted with a portacath at that point. So I've actually had 3 portacaths, I think, over the period of my life. And yes, so my mum gave me my treatment through a portacath until I was about 14, I think, and then I took over my infusion when my portacath got blocked. I got an infection in my portacath, and it had already been replaced, I think, twice at that point, 3 times. So I then took over doing my infusion, and a nurse came and taught me how to do it, and I did that for a number of years until I got to university. And then because I developed a tremor in my right hand, an intention tremor, it just wasn't possible anymore, which was really upsetting, actually, because, as we'll probably hear from Callum, I think being independent gives you it gives you the opportunity to be flexible about when you have it, and that's really important. So then I had a nurse come to university, and then I had a nurse up until last year when Callum took over my infusions. So yeah, that's a bit about my journey.
Okay, great. So you've had a mixture of nurses doing it, mum doing it, doing some bits yourself. So you've been independent, semi-independent, nurse dependent. So that's good.
Yeah.
So Callum, what what made you want to learn or get involved in giving Maddie her treatments?
Well, I think it was when I started going out with Maddie. She was very open about her condition to me, and I got to see firsthand how her treatment worked. You know, how she'd have a nurse come in. You know, she'd administer the treatment, but it was, on the one hand, it was very. It did sort of infringe on Maddie's freedom a bit. You know, we didn't know all the time when the treatment was going to arrive, what time of the day that would be. You know, had to be in the house for that period as well. It was all a little bit, you know, I think the idea was that if I were to take over, then we would be able to decide when we do the treatment ourselves. It would free us up. We wouldn't have to deal with the stress of, oh, what if it doesn't come this week and we have to wait a week for it. And then on another note, I really wanted to prove to my own side, I wanted to prove to Maddie that, you know, I would be able to do that for her, show my love for her, and that, you know, she could trust me with her life. So I think those are the two main sort of points really for why I wanted to treat myself.
Yeah.
Great. And can you talk to us a little bit about what training was involved, or what process you went through in the learning how to do it?
Yes. So I spoke to Maddie's nurse, who, lovely lady. She told her of what I wanted to do, and she said we needed to do 3 sessions where I would learn the process before it would be safe for me to cannulate for her. The first of those weeks was merely me sitting and very closely observing how the process works. She talked through the process. I got to see how all that cannulation worked. Second time, it was a bit of a duo. She did a bit, I did a bit. She helped me perform my bits. And then for the third time, I was to do it all myself, and she was observing how I did. Luckily, I think I got good marks for it, and so she determined that from then on I could be authorised to perform the cannulation myself. And since then, it's been great. I don't think I've had many mishaps with it. I think it goes quite well.
Okay, brilliant. Well done. And for you both, how does it impact on you emotionally, you doing it or being able to do it? Do you feel pressure? And then for you as well, Maddie, after we hear from Callum, how emotionally does it make you feel that Callum has taken this on and is able to help out in this way?
Well, to go back to your point, Niamh, on pressure, I certainly felt under pressure the first few times. I thought, well, I think I was told, well, if you get this wrong, Callum, this is really going to hurt. So it did leave a little bit of, you're nervous at first for it, but as long as it's not, once you've got the hang of it, it's not particularly difficult to do. I didn't, you know, after a few weeks, we've not had any issues really. There is a little bit of the old, there's a little bit of stress involved. You know, if I get it wrong, I might get shouted at or something. So, but that's all part of it, really. But I think another thing that not necessarily we have to face, but a lot of people will have to face, is that you are injecting a needle into somebody you love, and you are going to be causing a little bit of harm for them. And I think for some people there is quite a bit of a reluctance to do something like that, even if it's for a good cause. But I think once you realise what you're doing to them, you're saving their life pretty much by infusing them. It's that whole fear, I think, of causing harm melts away a little bit, and it's not. If it's something that you're worried about, I wouldn't be too concerned about it after the first few weeks. It's just those first hurdles to get over.
Yes.
Great. And you, Maddie, how did it make you feel that Callum A, wanted to do it, and B, is doing it for you? How's that been?
Yeah, so obviously I'm really proud of Callum and the fact that he felt strong enough that he was able to do it, because as he said, it's not an easy thing to do, to inflict pain on someone you love. But as Callum says, it's for a good cause, and I think you have to push through that feeling. For me, apart from being very proud of him, it's given me it's giving us a lot of independence, you know, and that's a really good thing, and that makes me feel a lot more calm when I'm having it. And also, I think to some extent that Callum now knows how I like to have my treatment, you know, the way I like to have it, and I don't need to keep explaining to Callum, you know, the different ways I like things done. Like, you know, I haven't got a very high pain threshold, but I probably have got a higher one than I think I have. But I think, you know, I like, you know, for instance, when he's like cleaning the injection site, I like to let it dry for like quite a long time beforehand. And, you know, when you have a nurse, small things like that, it is difficult to keep explaining that if you're having a different nurse each time, like, you know, the specifics about how you like things done. And I think it can be stressful when it goes wrong. You know, for me, obviously it's, you know, it's painful, but on a personal level, it's something that has to be done, and therefore I have to push through that pain, you know, take the needle out, you know, calm down for 10 or 20 minutes or however long, and then, you know, let Callum try and inject again, just because also, you know, for Callum's confidence, I need to be able to basically, you know, just almost be brave enough and just let him get on with it, because I have to remember sometimes not to make such a big deal about it.
Yeah,
if it goes wrong.
If that stresses me out, that's going to make it harder for me to get it right the
exactly.
second time. So.
Although I do try not to shout.
I think that's only happened once, to be fair.
Yes.
And, you know, you've always got a nice mug of coffee and a rich tea biscuit after the needle's in. So that's something that the nurses won't necessarily.
No, that's true. Well. That's true. So yes, I think from my point of view, that's how I find it. And you know, I think I even had this with Mum, though. It's nothing to do with Callum. I think that, you know, it goes against your instincts, and I think it does put pressure on your relationship, you know.
But whilst there is that, you know, I want to stress that, you know, there is the bit of pressure, but it honestly does bring you a lot closer together. For those little nigglings on pressure, it's really something we couldn't recommend more. You know, it does really help bring your relationship together and bond you more. So those little small hurdles it's worth it for the result you get.
Yeah.
That's fantastic, guys. You're an inspiration, and thanks for doing this, because I know there's a lot of people out there who are quite nervous about it, and it's nice to hear your story and see how it works, and you know that, and you're very honest in that there is pressure, but the benefits outweigh the negatives, if you like. So that's great. So thank you for sharing. Keep up the good work.
Thank you, Niamh.
I hope other people enjoy your story.
Yes.
Thanks, guys.
Thank you.
Bye.
I hope you enjoyed this story, because I did a lot. It's a very nice one. It makes me comfortable having infusions at home. So now we are coming to the part where we are going to share some stories about advocating for home treatment. And for this, we have invited Kate Theochari from Greece and Fernanda Torquati from Italy. And now I will give the floor to them. So Fernanda, maybe you will start and share a little bit about your advocacy regarding home treatment in Italy.
Okay, hello everybody. It's nice to see you all. What can I say? We've been advocating for many years, actually, and I can say that when my son was 14, he's 40 today, in Tuscany, they were training patients to infuse themselves. And it was a wonderful thing, because it meant going from hospital infusion to home infusion, because I learned and I was infusing him. And then he became independent, and it was very important for him. And then this was stopped. And it is now not allowed in Italy so far. We are advocating, we have 21 regions, each region does its own thing. And so we have to try to convince the regions to comply, because home infusion really changes the life of a patient. It gives them freedom, it makes them happy. And it's not just Gaucher patients. We are fighting for the Fabry patients, for the POMP patients, for the MPS patients, for all those patients who have enzyme replacement therapy, to allow them to be able to do the infusions at home. And in this sense, Tuscany has agreed to it, and we even have the POMP patients being infused at home in Tuscany. Not everywhere else, but in Tuscany, yes. And so it's a battle. We're going to go on with this. We're going to continue, because I believe you cannot have citizens of Class A and Class B citizens. Everybody must be equal, and all patients throughout the country must be able to do home infusions if they so desire, if they're able to do it. It's not fair otherwise. It depends on where you live. You see, that's not very nice. The next step, obviously, is to get it, to make it available throughout the country for everybody, with the nurse coming home or whatever it is, and then eventually to go back to the auto infusions, the patient infusing himself, which is actually 100% freedom for them. It would be if they learn to do it. We're still battling it. I mean, we've won the battle, but we haven't won the war yet. This is the situation.
Thank you, Fernanda, for this. You're an amazing person. And I'm very happy that I've met you and that I had opportunities to spend time with you and learn from you. And I would like to invite Kate so she can tell us her story. Kate, do you want me to share your presentation, or you will do it?
Wait a moment. Okay.
Yeah. Great. Excellent.
So Fernanda and I have met a long time ago, since Fernanda was the founder of the EGA, okay? Yes. So I think home treatment is a challenge for patients and health authorities. I'm the chairperson of the Greek Lysosomal Association. So we have all lysosomal diseases in our association. It has been hard work, and many people of our board, we have separated our work, and now other people on the board are have the, how can I say, not a responsibility, but they have the groups for each lysosomal disease. There have been many challenges and much history behind treatment in Greece. I'm going to discuss a bit about the patient journey and the access to treatment. In 1997, all Gaucher patients had to travel from all over Greece to Athens to infuse themselves. It was very hard because in Greece we have many islands, so you can think what happened back then when people had to leave their families, their jobs every 15 days to fly to Athens. Then the goal was achieved, but it was very difficult. After 10 years, all patients received treatment in local hospitals. One thing that we had to do about home treatment, because we had thought about it many years ago, was the empowerment of patients about it, about the better quality of life of them. And we had some patient meetings to convince patients about home treatment. And I remember Anna Greta was here about 10 years ago in our meetings. It was an amazing meeting. Then I jumped up to the COVID-19 period, March, September 2020, when all the patients were terrified to go to hospitals. So what we did as an association, we appealed to Red Cross and health provision organization services. So they, what they did was to drag and transfer patients from home to hospital and back. And finally, in September 2020, Sanofi and Amarin provide us now support to help meet the needs of patients through the patient support programs, which means they provide the drug to the hospital if needed, and then they transfer patients from home to hospital. So I think this was very hard work to convince the companies because we didn't have any other solution. Now this is going on at the moment. So we think a happy patient is an empowered patient, and this is all it matters. And the goal is now home treatment. Here are some psychological and social benefits of home treatment, what the Greek patients think about it. And I think patients all over the world is a more normal life for them and for the children. Children are not missing school or work. And there are many psychological and social issues because people work and unemployment is rising nowadays. And this is really hard for them. And also for school children, they've got many psychological issues when they miss school and everybody asks them what is happening in their life, and the parents, it's very difficult for the parents to do that. Less time to travel, to wait, less bureaucracy. Infusing makes it easier to travel. It's dependence for people to do that because they can travel, they can change jobs, towns, anything. It's better for the adherence to treatment, more time to spend on other social activities, and it makes our life easier and safe, especially due to COVID-19 and other health crises. So what are the patients' and clinicians' concerns? Sometimes we don't know if it's the right home environment to do the treatment, the stressful process, lack of education of patients and caregivers. If there's going to be a side effect, what happens? Is it going to be a response of the health system immediately when it is needed? The risk might be higher for some patients, and incorrect storage of medicines happened in the past, and handling of needles or syringes in an unsafe way. It happened because we had to carry the medicine from the central pharmacies to the hospitals in the past. Now, what are the proposed solutions? What can we do today? Who can organize all this? So our first priority is the centers of expertise of Gaucher disease. Now in Greece, we've got 19 centers of expertise for rare diseases, and one is for Gaucher disease. It was authorized lately. So we think the centers of expertise is the best, how can you say, the best partner in our solution to organize this. Then primary care can offer home treatment locally, and also if we got severe patients and patients in remote areas, equipped mobile units are available for other patients in Greece. And pharma industry is the last but not least, the one solution that to support home treatment through PSP. What we think, more than that, we think that when we have home treatment, we should have clear criteria for which patients is home treatment safe. Education of nurses about enzyme replacement therapy for allergic reactions, but also for recovery. And I think, and we think as an association, we should have protocol of home treatment of Gaucher disease and side effects. Obstacles. The regulatory environment, national state requirements. We have to have a change of legislation because in Greece, there is no legislation for home treatment for rare diseases, and also changes in the National Drug Organization, which means that they have to change the blue box of the drug, and it must state that it's also for home treatment. And this is a whole procedure. It's very difficult to change. And of course, there is no flexibility of the public health system, limited budgets, difficulties in cooperating with health authorities. Due to the COVID-19 period, we had a lot of difficulties, no recruitments in hospitals, no telemedicine, it's not fully applied, primary care difficulties, and a medical center system, which is not centered to the patient, not centered to the person, but to the medical, the hospitals, the health professionals. And of course, there is a very big gap with social care. So what are the challenges and what are the solutions? Is the collaboration with health authorities, the medical community and scientific groups, and of course, pharma industry when needed. The understanding from the health ministry of the cost effectiveness of having home therapy, which means that is going to be lower cost for hospitals for this. And of course, as I said before, the newly authorized centers have the experience and know patient history, but need collaboration and assistance from regional health authorities, need budgets, need staff. What could give an added value, we think, are the good practices of home treatment in other countries. The EWGGD protocol of monitoring home treatment and side effects, I think, is necessary, and the protocol of any national working group on Gaucher disease. So advocacy, we think, is difficult. It needs time, but also organizing. It needs prioritizing your aims, your goals, lobbying and pursuing your goals, which is something very difficult every day of the associations. Publicity gives patients a voice. I mean, during the COVID-19, our association was the only association that appeared on national TV about problems with benefits and problems with pensions, because everything had stopped, and the Center of Disability Assessment had stopped everything. And for many months, and until they just started in August, all these people have no money, no budget, no family budgets. So I think we should give this part of great importance, because I think publicity, through publicity, then the ministries and everybody can listen to you. So I think we have to continue sharing our best practices to reach our goals and offer good quality of life. And I think, and we think as an association, that opportunities are always out there for us, even in these times of health crisis or other times of economic crisis. Thank you.
Thank you, Kate, for this wonderful presentation. You are one of the other superwoman I know. I think that since I've joined IGA somewhere in 2012, I've met so many amazing women, superheroes that I love, and a lot of them are here in this panel list today with us. Amazing women doing amazing work in their countries, but also internationally helping out other patients. So now it's time for another presentation. I will share it, but the presentation is from Derralynn Hughes, and she's also an amazing person, a doctor caring for Gaucher patients, and she will talk about the EWGGD statement on home treatment. I will start right now.
Thank you, Vesna. Thank you all for asking me to speak today and to share this information from the EWGGD. And happy International Gaucher Day for everyone. I've got a little bit of background to start with, which I think is relevant to where we all are and our thoughts at the moment, but also why we felt it was an important time to have a statement on home therapy. So next slide. There's just some disclosures, and next slide. Okay, so we really came to this acutely because of the risk of SARS-CoV-2, which is the virus that causes COVID-19. And because we were really very unclear as to the impact that that might have on patients with lysosomal storage disorders, and particularly Gaucher disease. And when we started thinking about this, it was back in February and March when we had very little information, and our main priority was really to protect our patients from coming to any problems at all through COVID-19 as far as we could. What we've learned since then is that the risk factors that I've put on the slide here are the main ones for an adverse outcome from COVID. So being male, having diabetes, being overweight, having heart and kidney disease is a really important risk factors, particularly kidney disease, but also high blood pressure, immunodeficiency, and chronic lung disease. And so my feeling is that patients with Gaucher who, for whatever reason, have one of these factors, so older males or patients, for example, with lung disease, either as part of Gaucher or as part of something else, are at higher risk. We don't seem to have encountered a higher risk because of Gaucher itself, although we still need to collect evidence on that. Next slide. There's some preliminary evidence that there might be a relationship between storage disorders such as Gaucher and COVID. And that's because the cells that we're finding that are most impacted by the COVID virus are macrophages. So the very cells which are relevant to the pathology in Gaucher disease. So when we stain up the cells for various surface markers, we find that the macrophages that you would see in the spleen and the bone marrow and other organs that would potentially also be involved in LSDs and in Gaucher. Next slide. We certainly don't see any specific evidence that people with LSDs and Gaucher are at more risk of contracting COVID. And we all know that the best way of avoiding contracting really is to do that social distancing, keeping hands washed and keeping basically away from crowds and away from other people. Next slide. There's been some thoughts from some of my colleagues, and Shoshana Revel-Wilkes, also on the board of the EWGGD, of what might be the particular impact of COVID on Gaucher, and some thoughts that in fact the glycosphingolipids that accumulate in Gaucher disease, so the storage material in the immune cells, might actually cause some kind of immune tolerance, which might actually be a positive thing. Now, it's really early days to start talking about that, and my very strong advice is that all of you should follow the recommendations in your countries as to keeping away from people and washing hands and those things. But we're very interested to have the final data collection from the various services and hospitals that work with the EWGGD, trying to understand the impact of COVID on Gaucher. Next slide. Now, back in March, when we started to think about how best to protect our patients, it was all around isolating people. So we called it shielding in the UK. So asking people to go into their own space, their own house, form a little bubble with people that they live with, and basically not to have any contact with the outside world for up to 12 weeks. And that had a huge impact in terms of people's mental health, in terms of being isolated, unable to see family and friends and so on. And of course, it had a big impact on whether people could have their treatment. So for some people who had been having home care, we asked them to switch to self-infusions or to switch to oral therapy. And some people had home care interrupted. But for people who were coming into hospitals, of course, there was no option at all, and their therapy was interrupted at that level as well. Now, the isolation, the shielding, does seem to have been affected because there are very low levels of reports of LSD patients being significantly affected. But it was at a great cost of both people's mental health and potentially the loss of treatment. Next slide. And there's been a number of studies looking at what that impact means. And this is one from the Italian group who felt that for many patients, 49% of patients who were receiving enzyme in hospitals had interruptions in their treatment, but only 6% of those patients who are receiving treatment at home. So really significant impact on people's treatment. Next slide. So where are we now in terms of going into a second surge? And we see the numbers in terms of COVID rising across the UK and also already in some places in Europe. And so we felt it was really important to have a strong stand on making home care available for people. And of course, that's not just because of COVID, it's for many reasons that is of great benefit to people's individual independence, their compliance with treatment, ability to carry on working and having normal family lives that's not interrupted by regular visits to the hospital. But particularly at the moment, we felt it's important. There's also other considerations, things like remote consultations and remote monitoring and how we provide better care at a distance for our patients. Next slide. So because of all of that, coming acutely with COVID, but because of all of the background, we felt that it was important to make a statement on home care for enzyme replacement therapy for Gaucher disease. And I've spread that across 3 slides here, and I'm going to go through the bullet points very briefly. So we first of all gave some context that since 1990, when enzyme treatment became available, many patients have actually received treatment at home. And that has proven itself to be safe and effective. And I certainly have no concerns about my patients receiving treatment at home. I still have clinical responsibility for them, but the treatment is either done by themselves or by a home care nurse. And it's very rare that we have anybody with any problems that requires me to get involved. But in several countries, home care is not available, despite the fact that all of that experience has been written down. In the Netherlands, there's a long inventory of home care experience that shows that patients actually prefer to have their treatment at home, and we've also published in that area. Patients can have treatment with a home care nurse, or they can be self-supporting after really not an awful lot of training. Most people manage to pick it up very easily. And there's always the option of having some more support later down the line if you find that becomes difficult again for whatever reason. So both the enzymes that are available in Europe have been used for home care with 30 years experience for imiglucarase, and then Vela for 10 years or more. So a lot of experience for both enzyme, and the safety profile has really been established for both the enzyme. And in places where talyglucarase is used, which is not throughout the whole of Europe because of the licensing, but it has been used for home care where it is available. Next slide. So during the period of COVID, those patients who were receiving home care, and in particular were able to self-infuse, were able to continue their treatment uninterrupted. And we feel that's really important. So short interruptions, probably people are not going to find too difficult. But if the interruption is longer, then that may start to have an impact on patients, and especially people who are newly diagnosed or children. So we felt that it was important to have home care and then to have regular reviews, especially if people had missed treatment. Next slide. And then the final part of the recommendations were that if home care was going to go ahead, then it should be done in a way that is safe. So with compliance with infection control procedures by home care countries. So the EWGGD is very happy, along with IGA, to support any of you, any representatives in any countries where home care is not available, to try to enable that to happen, so that we're well equipped to continue treatment during this pandemic, but also anything else that might happen in the future. And also just to improve quality of life for patients not having to come to hospital on a regular basis. So I'm really happy to answer any questions about that, or to take any thoughts and ideas or concerns that people have about home care. So thanks, Vesna.
Okay, that was good. So yeah, now is the time for all the questions and all the answers and everything. And we are going to start with this one question from Anonymous, saying, I'm here in NYC on enzyme replacement therapy. I suppose that's New York City, over 27 years, and due to health insurance constraints, it is difficult to get home infusions because of health insurance reimbursement. If a person can afford to pay out of pocket, this is one thing, but it's not on public insurance. They will not reimburse for nursing charges, and there are also other reimbursement pitfalls. There is a lot of red tape around this, and the US does not see the cost savings involved with home infusions. So I'm not sure if one of the panelists can answer this, but if we have somebody from the USA that wants to, that have some insight on it, that would be wonderful.
So Vesna, just to say that Patricia from Guatemala has made a comment on that question. So I wonder if Patricia would like to say something.
Patricia, would you like to say something? I think we should unmute her.
Yeah, I have, but
hello,
maybe I
now can you hear me?
Perfect.
Yeah.
Okay. I'm sorry because I'm with my telephone. Look, I have an American insurance, even though I'm in Guatemala, because local insurances will not cover chronic diseases. So I made an arrangement with the Bupa, which is my insurance, and I made some numbers with them. The problem is that usually when you contact these insurance companies, you usually contact the contact center, the call center, someone who is not
Patricia, we lost you. We can't hear you.
maybe she'll come back.
Okay.
We should move on.
Okay, yeah, we can move on. Well, there is actually a question from Patricia saying, how can we manage problems with the veins, with the infusions? I know the patients manage this differently. So in some countries, they use ports, so they don't poke their veins all the time. Some people change, you know, this hand and now this hand, and now up here and down here, and maybe here. Then you give your leg, which is, yeah, well, you're just trying to get the vein that is not difficult to get, and that it's not painful. But in some time, it really gets, you know, annoying to get poked all the time. So I know that for me, switching to oral therapy was life-changing, and not the fact of not going to the hospital and the fact that I was not seeing needles anymore. So if anyone else wants to share about vein problems from a different perspective, this was me as a patient speaking, how I managed vein problems.
Maybe Niamh or Derralynn, because Niamh, obviously, you know, you've been very much involved in home care and patients with particularly with home therapy.
Yeah, I mean, sure. We have some patients who have difficult venous access, and it's hard. I mean, generally, they get there. We do advise them to drink lots of fluids, lots of water, often to have a hot shower, a hot bath before the infusion can help to bring the veins up. And generally, they do okay. In adults, we don't use ports or CVADs as much as we do in pediatrics, where it's very difficult. But generally, people are okay. They manage fairly well. Obviously, if they're really, really difficult, not able to cannulate themselves, we'll have the nurse go in and do that bit and then encourage patients to do the rest. So there can be a mixture of dependency for some people.
Thank you. Derralynn, would you like to say something on this, or?
No, I agree. I think sometimes it's just if the veins become a bit tricky and then people have one or two misses, then they get quite anxious about it. So it's probably then just good to have a little rest from it for a few weeks, get somebody to come in, help them out a bit, and then start again. It's people, I think the main thing is just not to get too stressed about it. Also to work out a regular routine of when you make up the enzyme and when you infuse it compared to when you put the needle in, so that you know if you're having needle problems, how long you've got to put the enzyme in, or do you put the needle in first, that sort of thing. So good to discuss that with your nurses and teams.
Yeah. Okay, now I would like to ask a question who is connected directly to the home treatment. So the question is, who pays the home treatment in UK, and how is this in Europe? Is there a legislation on home treatment, or each country finds their own solution? Well, we can start with the UK. We have 3 UK people on the call,
So the question is how it's paid, actually.
Yeah.
So there's a little quirk, a little unusual aspect of the law in the UK, which means that it's much easier to do home care, and that is that there's purchase tax, VAT it's called in the UK. It's 20%, and if a drug is prescribed in the hospital, you pay 20% tax on it. But if it's prescribed in the community, you don't pay that. So that 20% saving pays for the home care. So that's worked really to our advantage in this situation, and obviously is not going to be the same throughout the world. So we've not had to battle too hard about the payment, because even with the 20%, it is still a cost advantage. And then there's a related question about what proportion of patients that are on enzyme replacement in the hospital and home care. Well, because of that cost saving for doing enzyme at home, it means that pretty much all the patients are at home. It's our standard of care. So the default for us is home care, and there has to be a good reason for people to have to come back. And because people like home care, that's actually worked very well.
Thank you. Yeah, so I don't think there is EU legislation on home treatment, and it's not just up to the countries, it's also up to the hospitals and the clinicians and the decision of the families and the patients. So it's not something that just happens. It has to be, first you have to have it on the medicine, when they register it, it has to say on it that it's allowed for home treatment. If you don't have that in the SMPC, then it's almost impossible to get it for home treatment. Maybe Kate or Fernanda can speak more about EU legislation.
Well, during the COVID thing that's still going on, for example, the Italian Association for Pompe's Disease was able to obtain in Tuscany the possibility to do the treatment at home, and it's paid for by or either it's the private companies come in, or it's the hospital who has you said they hire a nursing company which goes to the home and infuses the patient. So even though in Pompe's disease nothing's written, you're not allowed to have it at home, these patients were allowed to have treatment at home, and it worked very well for them. It's 6 hours infusion. Think about it. 6 hours it's terrible. So actually what happens here is that generally most of the patients, we have the private industries that have a home care situation established, whereby neither the hospitals or the patients pay for the home care treatment. And sometimes some regions also have their own private, let's say, nursing system, and it's paid for by the hospital, by the region. But the majority is done by the industries who hire companies to go at home.
Yeah. Thank you. Yeah. The infusion time is long, and also the travel time is long. A lot of people have to travel to get to the hospital, and they have to take the day off from school because the hospitals don't take them on weekends. So they have to take a day from work, and it all goes on. And you can't go alone sometimes. You need somebody to come with you. So that person should be free to be with you also. So it's definitely home therapy is something that gives more freedom. So I have Paul here, Gujit, saying that in Netherlands and UK and France, they have decades of experience with home infusions, and he proposes that these three countries join together to write one or more condensed best practices from the perspective of the patient, the nurse, and the physician, and also try to touch on the legal and the economical aspects, which is a nice thing to do, actually. And maybe it would be a good idea for IGA to take on a project about home treatment and see if we can gather all the best practices together and share them with all of our members. Excellent. Okay, so Jasenka from Croatia has some technical questions for countries where home therapy is available. Where do you pick up your medicine, in the hospital or in the pharmacy? Who picks up the medicine and brings it home? Is it the patient, or is it the nurse, or is it the pharma distributor? And how many treatments can you get, like just for one time, or for the whole month, or for 2 months? How is it done?
So I can answer that for the UK. So here we have nationally, we have a framework where we have 4 home care independent companies who work for us, and they provide delivery to the patient's home and nursing support if needed. So either way, the drug is delivered directly to the patient's home. Now, if someone's on fortnightly infusions or an infusion every 2 weeks, we would only deliver 1 month's worth at a time, so 2 infusions worth at a time. And that's just because of risk of the product getting spoiled or left out, or someone getting sick or something like that. So every month they would have a delivery before the nurse comes or before their infusion is due.
In Italy, now with the COVID thing, you have the infusion, the medicine is delivered to the patient's home. Even the oral therapy is delivered to the patient's home. But before, the patient had to go to the pharmacy in the hospital to pick it up. Now it's all delivered at home. And in any case, it's one infusion every 14 days. They don't give you extra the medicine for an extra infusion. Every time they come home, they bring the medicine with them at the patient's home. In Greece, I don't know.
In Greece, for 2 years now, we have patients can get their drugs at home, but they have to pay about 40 euros a month for that. It's not on the public health system. So it's very difficult for patients to pay that. But they can do it only for pills or for some other medicines, but not for lysosomal drugs yet. But they have started 2 years ago, and now they're putting on other drugs. But the problem for us is that the drug organization is difficult and also always put us, you know, some hurdles, and they say it's very difficult to change the blue box. And I think this is, as you said before, Vesna said that, I think, about we have to do that, okay? We have to change the blue box, and we have to convince them to do that. I think when we have solved this, then we can find many ways to have home treatment.
Of course.
Yes. Yes, and we think that the Center of Expertise of Gaucher disease, now where I have my treatment, can start as a pilot program. If they started as a pilot program, you know, things go in Greece step by step. If you have that, then everybody takes, you know, on and goes on with it. So yes, we have such services, but not for lysosomal diseases yet to transfer medicine. But the companies now do it. I mean, BioMarine and Sanofi do it. And I think Takeda will also do it.
Takeda does it too.
But in Greece, you know, BioMarine saw that Sanofi started, they understood the concept, you know. And then I told them, you can also, and now it's Takeda, I think they will do it. I believe that, that they will do it. Okay.
Yeah, so it's nice that we have pharma companies helping out and supporting home treatment. So Irena from Slovenia, she shared that she actually picks up the medicine in a local pharmacy. So just before the infusion, she goes to the pharmacy, picks up the drugs, takes the infusion, and that's it. So it's very convenient for her and very easy to do it. Now, Kate, we actually have a question from Greece. As Maria says, we are still not having home treatment. Can we have a statement from IGA for best practices? Or can EWGGD have a protocol with home therapy and side effects? So I'm not sure if there are specific side effects from home therapy.
So I hope everybody's aware that it's the 14th EWGGD scientific meeting in 2 weeks' time. And we're going to devote the Monday morning to working groups related to guidelines, clinical guidelines, scientific and so on. And you're very welcome to join some of those groups. It should be on the website. But one of them will be about clinical practices for Gaucher, and we can think about home care and how that would formulate a guideline, specifically with this end to help those countries where it's not yet available. So how do you do it? What is the best practice? What are potential pitfalls? And then maybe some data around how frequent they are, because you've obviously there's some reticence in some countries because of a perceived risk of having a clinician overseeing something in somebody's home. And I know that's part of the story in the US, that it is also, it's a it's a concern about risk as much as anything else. There's two aspects to the US question. One is the payment model, and the second one is the risk.
I don't know, for years the hemophilia patients have been infusing themselves almost daily, right? And there's never been any problems. And I don't think there should be any problems with Gaucher patients or other, if they're taught to infuse themselves, or if they have a nurse or somebody coming to the home. I mean, there's never been any problem here with.
No, so the reality is that there isn't, but there's a perception that there might be in some countries.
I think some countries are just afraid to lose the patients, or the idea of having the patients in the hospital in case they want to do some kind of experiment or something like that. This is my impression.
Some moment. Okay, so we have more answers in chat about home treatment, and now I can see that in Netherlands you can get the treatment in the local pharmacies. In France, you get the treatment in the pharmacies that are in the hospitals. And okay, Patricia says that in Argentina, that Sanofi and Takeda as pharma companies are providing the service of home treatment delivery between 3 to 6 months of therapy to the adult patients in Guatemala, but it depends on the provider, and you have to be less than 5 kilometers of a hospital. So then we have Suyok from India saying something about how complex it is to have home infusions in India, especially after COVID-19. Suyok, would you like to actually speak about it? Tanya, can you unmute him? Thanks.
Yeah.
Sorry, what is the question? Can you repeat it, please?
You were just commenting on the situation in India and about home infusions. So maybe you want to explain on that.
Okay. No, actually, I have not commented anything, but still I'll answer that question. So in India, in India, there is no provision for home therapy yet. So most of the patients still have to visit the hospital despite the COVID situation, and some of the patients also have to skip the infusions, to avoid getting infected. And yeah, that's about it.
We have other comments. So Irena saying that she has a telephone number of a doctor, and if something gets wrong, she can call the doctor while having an infusion and get some help on that. So this is good. Having a phone number from a nurse or a doctor who can come to your help and support, it's actually great. Now we have another question saying, do you think that medical schools must prepare the next generation of physicians for the inevitable shift from hospital to home by integrating home-based care into required training? So this is a nice comment, and I would like to say yes. I think so, but I would leave you to comment on that while I give my daughter a tape.
Yeah, so I think it's really important that as a whole service to patients with Gaucher, LSDs, and probably pretty much anything else, we should be thinking about how we can do things closer to home and avoid having people coming to major hospitals on a regular basis, both because now of COVID, because of other things that might happen in the future, but also to improve life for people. I think we've had a model that's all been centered around the hospital. People come up for tests, come up for assessments, come up for treatment. We probably do too many tests, so we've got to get the level of testing correct. And then rather than basing the model around the major hospitals, let's see if we can base it around the patient and the patient's home and have more of a balance. There'll still be a need to come up to the hospitals sometimes, but I think the whole shift now is to do things remotely. And yeah, I think that means training people from medical school onwards. It'll be much more natural to people going through medical school now than people trying to change their practice when they've been around for a long time.
Okay, thank you. So I don't think that we advertised that people can register to EWGGD online. Derralynn, would you like to say something, and I will find the web page and share it?
Yeah, so on the Monday and Tuesday week, 12th and 13th, we have the EWGGD. It's online. We sad about that. We were hoping that we'd be able to get together in Leiden, but along with any other meeting, we are all now meeting virtually. So the Monday morning will be working groups, and then Monday afternoon and Tuesday afternoon will be scientific. Tuesday morning, there'll probably be some board meetings and so on. So, you know, everybody is really welcome who's affiliated with IGA and EWGGD. Very interested in your input, and because this is virtual, it means that it should be a lot more accessible to everyone. So hopefully we'll be able to see some of you there.
And for IGA members, just to let you know that you will soon get information on how to register to EWGGD and have access to the presentations and the lectures as a patient representative, which is nice having this cooperation. Patients, doctors, researchers, I think that we will achieve much more as we are doing it right now. So I will stop sharing this and I will share something else now. I'm sorry, I'm just sharing stuff. So I have another thing to share with you, as I don't know if you know, but as IGA we have a lot of webinars happening, and one of those webinars is actually coming very soon, and that's on 5th of October, and here it is. So on 5th of October at the same time that we meet now, and it's AAV-based gene therapy for neuronopathic Gaucher disease and Parkinson's disease with the GBA mutation. Okay, so while you look at this, I have to read through the chat. Joyce sharing the link for so you can register. That's good. I will be happy to see people. So now it's the time if you have last questions or something to add to the discussion. Otherwise, I will give Tanya the opportunity to start a little poll for all the attendees, so we can do some polling and see. Do you see the polls now? You can vote now on the poll. You can answer the questions like, is home therapy allowed in your country, yes or no? Is home therapy is allowed? Do you receive your treatment at home? It's all, you know, yes and no questions, very simple ones. Just tick the questions. hope you're answering. I don't know if you are or not. I really don't. Host and panelists cannot vote, so we have no idea what's going on. That's nice. Okay, so for the question from USA, I think it will be good if you get in touch with, you have two organizations in USA dealing with Gaucher disease that are wonderful, and we can send you contact from Aviva, who is also a board member in IGA, and she will probably help out with this. I will just copy the email of Aviva and send you in private message. And she can be of more help. Okay. So can anyone from the chat tell me if you've done the poll or not? That would be nice to know. That's nice. People saying they did it. That's good. We only have like 10 people who actually did the poll. So if you can do more, that would be great, because this is a feedback that we need from you so we can continue further with all the work that we are doing. We are not doing it for us personally. We are doing it for all of you, for all of us. So IGA exists because of its members, because of the patients and the families. We have 50 attendees at this point, and only 15 who answered the poll. If we can get a couple of more, that would be great. In the meantime, if anyone wants to share a comment or opinion, you're welcome. We are here to talk. And of course, there is still time for questions. In the meantime, I want to say that I'm very happy that we had this webinar on home therapy. First, I was thinking, you know, hour and a half, maybe it's too much, but I guess with wonderful people and wonderful attendees and participants, it's quite, the time went just very quickly for me. And I love that we had a lot of questions and a nice discussion. Of course, our speakers were sharing their experience and information, which and we are very grateful for that. And I have to say that IGA will continue with these educational and informational webinars and discussions. And I hope that we will contribute to sharing best practices and knowledge that's of importance for all of us, because when we do work together, we work better and we do a lot more for the patients and the families and for the quality of life. So thank you, everybody. Tanya will now stop the pooling and we are going to finish this webinar. So just to share some of the results from the pooling. 50% said home therapy is allowed, 50 not. The treatment is received at home, yes 50%, no 50. The provider 70% Sanofi and 28 Takeda. If home therapy is allowed, have you switched to home therapy during the pandemic? Yes 22%, no 50, and was already having my treatment home is 28%. If home therapy is not available in your country, are you currently advocating for it? You have yes in 67%, no in 17%, and would like to, but don't know how in 17%. If you're not currently receiving home therapy, do you think your quality of life would be better if you could receive your treatment at home? And we have 83% saying yes, which is, you know, a really it's a large number, and I agree with that number. I think it's much more comfortable, especially with therapies that you have to receive your whole life, so it doesn't stop. It's not just once or twice, it's your whole life. So thank you again. I will mention that you can join the campaign on social media, share our posts. You can search for International Gaucher Day. It will be very easy to find it. And let's raise awareness about home treatment, make it available for more rare diseases, for more patients who want to be free in their life and more happy. Thank you.